So it's always, currently, if you look anywhere, comparison is either you have this big cut or the tiny hole and get the aortic valve done. But we have to understand there's something in between. The reason it's not popular is we are practicing it less. So I think we have to adopt this technique. It's not about being competitive, it's about giving the best to the patients. End of the day, there is still a group of patients who need surgery. So the best way to adopt and start for the younger generation is minimally invasive mini sternotomy AVR, and then move on to right anterior thoracotomy. Now the new surgical armamentarium is robotic assist AVR as well. So the upper hemisternotomy is nothing different. It's just getting used to looking through what we need to do, and rather than just feeling and looking at the whole heart. So it's easy to start, same as the normal traditional procedure, just getting used to working with a small field. And patient is happy because he goes with a small cut, and it's usually the lower half of the sternum that's troublesome. See, the infections, pain, movement starts at the lower half. So when just the upper half, most of them get back to normal activity within a month, including driving and heavy work. The other, really moving on to minimal invasive approach, is the right anterior thoracotomy. I would suggest that best to be comfortable with upper hemisternotomy, at least 10 to 20 patients, then move on to this. And it is always better to do a CT, not necessarily contrast, it can be non-contrast chest CT, to assess the aortic valve. So it should be less than 10 centimeters or preferably less than 8 centimeters from the lower border of the sternum, and at least 50% to the right. It's a good way to start, at least for the first 20 cases. Because here the learning curve is a little more than the upper hemisternotomy. To get comfortable, it needs to be 20-25 patients. So apart from this lung function test, if there is any, we routinely do lung function test in any smokers and make sure the FEV1 is at least more than 50%. And best to avoid poor LV in the early phase. More than 45% is not a bad option. Of course, angio as usual. Femoral cannulation, I won't go into much of that. Then right anterior thoracotomy, the space depends. It's second or third space. I go with the Marc rule, which is the first space below the clavicle is not for us. Leave out the second space and then the third, which usually corresponds to the second or the third space. And once we open, with the instrumentation, it's better to use all traditional instruments for this, except flexible aortic clamps can be helpful. It gives us more room to work with because it stays away. So what we do, once we open the pericardium, just feel the root. If the root is below the space, then I cut the costochondral junction below my space. I always divide the mammary, but it's not necessary. Most surgeons don't divide mammary nowadays. And if the root is felt at the space or above, then we cut the costochondral junction above the space where I've made the incision. That gives us a lot of room, and the exposure is important. The most important procedure or step to make this procedure easy is to hitching the pericardium. We hitch at least 6, or if necessary, even 8. That's the corners, and 2 in between, maybe even the upper and lower part as well. And I always insert a right superior pulmonary vein vent before hitching the pericardium on the surgeon side. Then it's pretty much standard procedure. So this is the cross clamp, flexible clamp, which keeps it away. And the common problem might be if we keep the aortotomy a little higher. We have to go really low. So 1.5 centimeters or so from the annulus makes it easier to use the right coronary cusp sutures. But if we are using sutureless valves, we can go slightly higher, which will be a good option to use in these procedures. Myocardial protection, it's personal preference. We use cold blood, and there's no standard way of doing it. We don't use retrograde. It's too expensive. And that's what the patient goes home at the end of the procedure. And when they come down in 2 weeks' time, they hardly see a scar, and they're pretty much back to normal. It is really beneficial. and it gives way for future redo if required, which I will talk about in a minute. The next is robotic assist. I'll talk about this in my next talk on robotics. So slightly lateral incision, 4 ports. And I believe, we haven't started yet. We are moving towards it. So it gives us better exposure, but there are certain technical steps which we need to work around. 2 aspects we need to consider in this day and age, because we are doing more younger patients. So we need to develop the appropriate procedure, probably minimal invasive, and the appropriate valve for the patients as well. With the new bovine pericardial valves that are longer lasting, it is an option to provide to a lot of young adults. Yes, as Dr. Vijay spoke, for the teenagers, there are other procedures, but for the young adults, this may be a good option to work with. There are the 2 common bovine pericardial valves are Avelis and Inspiris. Both have their advantages. Avelis has a bigger opening, effective orifice area, and Inspiris has a resilient tissue in younger individuals. Sutureless valve is a good alternative in minimal invasive procedures. So this was a very recent study published just about a month ago, where you can see of all these valves with a 27 millimeter label size, the older tissue valves have much smaller effective orifice areas. Of all the Medtronic, Avelis has the biggest. Edwards Inspiris the next. And we also need to make sure they are TAVI compatible, because that's what we are moving towards in lifetime management of these young patients. So this is an Avelis valve, where you can see it's a non-metallic stent now, so it can break in with the tissue valves. The valve geometry fits in for a future valve and valve, and also their interior mounted leaflets. So there's less risk of coronary obstruction for future valve and valves. Indications have been evolving as well. The recent European and American guidelines, which has already been quoted in the morning, does not give us age limit anymore. Yes, it is 60, 65 cutoff, but it is vital for us to discuss the options with the patients. And it clearly says 2A indication, bioprosthesis should be considered in patients for whom there is a low likelihood or low operative risk in future redo valve surgery. So that's something we have to consider. Excuse me. So the lifetime management of aortic valve disease is a new concept, where in young patients, we discuss options. And if it's a biological valve, there is an option of minimal invasive. When even in young 30, 40-year-old, we give the options. If it is minimal invasive, then the first time redo is as simple as a primary operation. So that's where we are moving towards. In our practice, primary standalone single valve, almost 99% of them are minimal invasive, whether it be mitral or aortic. Then open surgery, and then valve in valve. So this way we can avoid anticoagulation, which just not only is it the cost, but availability is a big factor in our country. Availability and reliability on the procedures. We all come across the day-to-day problems. And again, we have to always keep in mind the TAVI procedures. Multiple studies have been done, and of which Notion is one which looked at young, low-risk patients. Again, they have come up with 7 years data as well. There's no big difference in mortality or stroke. Yes, there is a difference. So in SAVR, there is bleeding and atrial fibrillation. In TAVR, with aortic regurgitation and PPI, but this was with first generation valves. So second generation, the newer studies are showing less risk of pacemaker implantation and less aortic regurgitation as well, or paravalvular leaks. So it is about, again, working together and also adopting TAVI techniques to work with as a heart team. So we don't need to be worried that we'll be losing the surgical valves. There's still a big role. Like the stents, when it came, we are not losing our jobs. It's about working together and giving the right for the patients. Patients with aortic insufficiency, bicuspid, not all bicuspids can be done through TAVI. Most of them still need surgical valves. and young, low risk patients, concomitant procedures, patients who want to have mechanical valves, and high risk anatomy or horizontal planes. So that's where SAVA still will hold a role always. If you look at all the literature, we have noticed it's often the comparison between open and the TAVI, but there's very little cohort studies comparing minimal invasive with TAVI, where there's advantage of both mortality risk as well as less risk of other TAVI related complications. So I would like to conclude saying, please consider this middle option. And I think we should move towards more on this option for younger patients. And yes, for high risk patients and slightly older, we offer TAVI, but not necessarily always open procedures. So we all know the advantages of minimal invasive, apart from low risk of infection, quick recovery. It needs to be addressed in lifetime management of aortic valve replacement in younger patients as well. Thank you.